Hello, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Aaron Fine for MS Focus, and I'm joined by Dr. Adrienne DeBerry, who will be talking to us about why lab work matters. After a presentation from Dr. DeBerry, we'll open it up to your questions and comments. Now, I'm delighted to introduce our speaker. Adrienne DeBerry is a clinical pharmacist at UF Health Jacksonville and is a clinical assistant professor for the University of Florida College of Pharmacy. She received her doctorate of pharmacy from the University of Florida College of Pharmacy in 2012. Upon graduation, she completed 2 postgraduate residency programs, with a second specializing in ambulatory care. She is board certified in ambulatory care pharmacy and is certified in specialty pharmacy. Her areas of practice include neurology, pain management, and specialty pharmacy. She has held leadership roles in multiple professional pharmacy organizations and is passionate about patient education. We're pleased to have her join us to present this important topic. Dr. DeBerry, thank you for being with us, and I'll turn it over to you.
Thank you so much for that, Aaron. So today I wanted to take some time and discuss with you all about the importance of laboratory monitoring. A lot of times when we think about our healthcare and our visits to our doctor's office, monitoring and blood work kind of tends to be a bit of an afterthought. So I wanted to take some time to get you all familiar with some of the common tests that you may see or have had ordered for you by your provider, as well as give you some tips and food for thought on the next time you have to have a blood work done and to make sure that you do get it done in a timely fashion. So first, I'd like to open up with this little comic. It's kind of related to our discussion today, but in the first box, you have the surgeon or the physician walking in saying, "Sorry for the wait, but we ran all the necessary tests just to be certain. And I'm happy to report that I am Han Solo from Star Wars." And then the patient asks, "Han Solo, are you talking about one of those online quizzes?" And then the practitioner says, "Test, yes. But what about my results?" "Well, you were an Ewok. Also, your lab results came back positive for a bunch of other stuff." And the patient sits and says, "Ewok, really? So this scenario may be a little bit playful, but it's not far off to some of the sitting and waiting you may have experienced with some of your healthcare providers. So today I wanted to take some time to discuss some of the key types of blood work and lab monitoring that may be requested for you as a patient, why the lab work is important, especially in the case for multiple sclerosis patients, and ways not to forget about doing your lab work in a timely fashion. And some of you all may be wondering, why is a clinical pharmacist talking to me about blood work that my prescriber orders in the clinic? Well, I'll tell you why. A lot of times when we think about pharmacists, we relate pharmacists to retail pharmacy. So we're thinking about going in and picking up our prescriptions, the person who's overseeing any drug interactions when we're at our filling pharmacy, and answering any questions for some of our over-the-counter needs. However, we also have pharmacists in a variety of other places, including outpatient clinics. So my role currently at UF Health Jacksonville is I am an outpatient clinic-based pharmacist. And some of the things that we do in the clinic as pharmacists, while we're working side to side with your nurse practitioners or physician assistants, as well as the physicians, is to help facilitate problem solving for issues related to medications. So we can assist with helping with medication access issues our patients experience, also providing in-depth patient education on complex medications, doing injection training and technique assessment for patients who may be on injectable medications, as well as provide consultative services for prescribers on complex cases. So for instance, if there is a patient, let's say they have multiple organ failure or issues with their kidney and the prescriber is trying to decide between maybe 3 therapies, and we kind of help coach them through that process of looking at different laboratory parameters and making sure that the safest choice is selected for the patient, as well as finally helping with screening and tracking of laboratory monitoring. So that's going to be our focus for our discussion today, is really taking a look at some of those laboratory monitoring needs that MS patients have. And while we all may not be perfect, there's a lot of times barriers that can prevent us from getting our blood work done in a timely fashion. Here are some examples of some of those common barriers, such as location. A lot of times insurance plans will place restrictions on where the patient can get their blood work done. So they may not be eligible or able to get their blood draw or their blood work done while they're at the clinic visit. Sometimes the labs may be a far distance from the patient if they're visiting a freestanding facility like Labcorp or Quest Diagnostics, for example. It may be a bit of a trip for them to get to those labs. Timing also can play a role as a barrier in getting those labs done. So for example, if you're in a location that doesn't have a lot of outpatient lab facilities, there may be a wait list or an appointment schedule on their terms that you'd have to work around. So for instance, if you happen to work Monday through Friday during regular business hours, and that is the only time that those freestanding labs are open and they're not open on weekends, you may have to schedule some time off from work or make it work around your family schedule to try to complete those blood work orders. Another thing that plays a big role as well is cognitive challenges. Sometimes we just forget. And particularly with multiple sclerosis, there can be some cognitive changes that come across with the disease itself. And it's estimated that about 34% to 65% of MS patients have some type of cognitive change just from the disease course itself. So you may just forget. You may be juggling a lot of things on your plate at a time and perhaps maybe upset about a diagnosis or having a particular tough time in taking care of your health at that moment. So it may have just slipped your mind. When we talk about the different types of lab work, it's not just particular to blood work. So blood samples tend to be the most common that most folks are familiar with. However, urine samples as well can be used or under the term lab work as well for some of our medications that we're taking and monitoring. Now, there may also be additional tests or screens that may be required as well that may need to be sent off to the lab or assessed as a lab work test, such as sometimes the skin TB testing, for example. Now, when we think of blood work, there are a number of different types of hundreds really of different types of lab tests that you can order, but I wanted to review some common examples of lab tests that you may see or that you may be familiar with or have heard about, or perhaps even have had ordered for yourself. Now, when you're looking at your medical record, or sometimes if you hear a healthcare team kind of discussing different laboratory markers, you'll hear a lot of letters thrown around. It's almost like an alphabet soup. The medical world really does love their abbreviations because it just makes things go by somewhat faster. But to patients, it can be very confusing. So here's a list of some common examples of lab tests that may have been ordered for you or perhaps will be ordered for you in the future. The CBC, for example, is a complete blood cell count. Now, this particular lab order set includes a slew of individual test results for different components that are within your blood cell system. So it's used to check on your white and your red blood cells. It's very useful in MS because it can give us insight into infectious risk. So determining whether or not you're having elevated white blood cells can kind of translate over into whether or not you may have a presence of an infection. Similarly, with MS being an autoimmune condition that is a result of an overreactive immune system, the CBC count can actually give us insights into some of our drug effectiveness in the multiple sclerosis world, but a little bit more on that later. You may also hear the term with differential added on to that, so a CBC with differential. That's a bit more specific and has additional absolute counts for certain blood cells. Lymphocytes in particular are something we pay attention to when monitoring our multiple sclerosis patients, particularly within that panel subset. A CMP, or a complete metabolic panel, is a pretty broad panel that includes electrolytes, minerals, and different other subgroups to kind of just check on your overall health. It can be used not just for multiple sclerosis patients, but really these tests can be used for anybody. And what's nice about the complete metabolic panel, it includes some enhanced subsets that it checks on. So compared to something called a basic metabolic panel, which includes most of the things that are on CMP, but some that are not, it's important to look at the complete metabolic panel, as it does give us a wider window into how the patient's overall health is. Moving on to liver function tests. So these are a set of tests that look at different subsets of your liver function. So things like your liver enzymes and how well those are working, or if they're working too hard and becoming stressed out, are an important part of interpreting this test. For example, when your numbers on your AST or your ALT increase, it's indicating that your liver is stressed out and has a bit of impaired function. Immunoglobulin tests give us information about immunoglobulins, which are used, and the immunoglobulins play a role in fighting off infection. And there's a variety of different subtypes of the immunoglobulin tests, but there's a couple that we pay attention to for some particular drugs in the multiple sclerosis world. And this is a common response that I hear in clinic from patients when I say, hey, it's time for this particular blood work. But I already just had that blood work done. My primary care doctor just did a bunch of blood work. Why do I need this blood work? Well, just because they're taking a blood sample from you doesn't necessarily mean they're running the tests that are of importance for you for their multiple sclerosis management. So remember how I mentioned the BMP, or the basic metabolic panel, and the CMP, or the complete metabolic panel. Here we have a list of each marker that's included in those two subtypes of blood work. And as you can see, the bulk of them are similar, but on the bottom, you'll see an additional ALK phos, ALT, AST, bilirubin, and albumin that are added on to the CMP. So as you can see, it does give us a wider view into the patient's condition. Thyroid test is completely separate from any of these metabolic tests. So depending on what test your prescriber has run, it may be necessary to draw additional blood work because we didn't collect the things that are important from a neurology standpoint that we need to check on. This slide includes an example of one of those tests that a patient may have to go back and get, even though they may have had a general blood work panel done recently. So this is an example of a quantiferon TB gold test result. And as you can see, it does include a lot of different markers that are included, as well as reference ranges and how to interpret a negative versus a positive for those tests. So I wanted to take some time and do a quick poll question, which you all can comment within the chat, yes or no, or Y or N, but have you ever forgotten to get your blood work done following a visit with your provider? I know I personally have. So it may be something that you, oh, someone's got a couple of no's, a lot of no's, that's awesome. So you guys are pretty much on top of making sure you're getting it done. So that's good. But for those of you like myself who may have forgotten to get a lab work done, you're not alone. So let's look at some research in regards to how often this really occurs. So there was a study that looked specifically at multiple sclerosis patients that were started on oral treatment therapies. Now, this particular paper was published out of a research team from Canada, but it had some very interesting results that I wanted to share with you today. So the goal of their research was to evaluate whether laboratory testing adherence was done by patients who were started on oral disease-modifying therapy for multiple sclerosis. So the oral treatments that these patients were on that were included in the study included Tecfidera, Gilenya, and Aubagio. So these are pretty common oral treatment options that some of our listeners may even be on as well. The researchers looked at their adherence to the requirements for liver testing, lymphocyte counts, and urinalysis testing that's recommended and required for these oral treatments. Testing intervals were specifically based on what was recommended by the drug monograph or that prescribing information. So prescribing information is basically, I would say, everything you need to know from a medical standpoint about the prescription product that you're taking. That's the one that usually has all the scary sayings about this may potentially harm your liver or XYZ. So in this study, there were over 1,000 patients that were included, and this slide depicts the breakdown of what therapies those patients included on the study were on. So as you can see, a bulk of the patients were on oral dimethyl fumarate or oral Tecfidera, with a close second being Fingolimod or Gilenya. Now, something to remember, all three of these drugs are in different drug classes. All three of them have different mechanisms of action, and all three of them have slightly different recommendations in regards to the timing of some of the required tests. So if you look, I think our slide may have gotten cut off a little bit. But if you're looking at the dimethyl fumarate, it's recommended to have a CBC and liver function test within 6 months at baseline before starting treatment. Ongoing tests would include a CBC, liver test, and urinalysis within 6 months of starting treatment, and then every 6 to 12 months thereafter. Now for Fingolimod, it's very similar at the baseline for their pre-testing with the CBC and liver test done within 6 months. Now, when you're looking at the liver test from an ongoing standpoint, it's actually recommended to do it periodically, or until 2 months after the treatment has stopped. Now for teriflunomide, it's a little bit more of a higher risk agent, so there's certain additional tests that need to be done at baseline. So for example, teriflunomide can actually be very dangerous to unborn fetuses, so it's recommended to get a pregnancy test for patients to make sure they're not pregnant before starting this therapy. In addition, the CBC and liver test recommendations are to be done within 6 months before starting the treatment. It also recommends to have tuberculosis testing before starting therapy. Now, when it comes to ongoing monitoring for teriflunomide, it's a little bit more labor intensive. So patients are to test their liver monthly for the first 6 months. So for 6 months, you're getting a blood work every month just to make sure there's nothing going on with your liver while you're starting the therapy. Then once you clear that 6 month window, it's every 6 months thereafter. So it gradually gets a little bit better, and you're not having to go through monthly blood draws as time goes on. Now, when we look at the results from the trial, this slide depicts the results for our dimethyl fumarate population. So as you can see, compliance was pretty high within the 90s at the initial onset for our liver testing, as well as for our lymphocyte testing. Now, the urinalysis testing was not that great for pre-treatment, with just over 75% of patients being compliant with that testing. And I will say, just from a clinic-based perspective, it's important to emphasize that this urinalysis, as well as the blood work, is important for us patients to have done prior to starting treatment. Now, moving on, the liver and lymphocyte testing remained high in compliance for the months 1 through 6, as well as months 7 through 12. However, that urinalysis monitoring component did kind of drop off as time went on over that 12-month period. Moving on to the Fingolimod results, we see again very initial pre-treatment lab testing compliance being very high in the 90s range for compliance within that time period. Now, when we look further on, the liver test requirement for Fingolimod is just within 6 months. So that explains kind of that wiggle room within month 1 to month 3, where it took a dip and kind of rose again in month 4 to 6. Well, again, the patients did have wiggle room from the prescriber standpoint of getting that blood drawn between that 6-month period. So kind of, I would say if you don't think about that month 1 bar for the liver test, it's a little bit more consistent with looking at 4 through 12. And then the ongoing compliance for that liver testing range from 67% to 55%. So we're seeing here where the Fingolimod compliance was definitely lower than the Tecfidera compliance over time during that first year of treatment. Now, if you recall, I mentioned that teriflunomide is pretty cumbersome when you're starting it as far as getting your blood work, because you are getting that monthly blood work testing every month for 6 months when you start therapy. The compliance rate, again, at pre-treatment remained very high again in the 90s, but we see an abrupt decrease in compliance with this testing as time goes on. So month 1 through month 6, we see our compliance rate range from 40% to about 25%. So we can infer from this that more frequent monitoring may not necessarily be conducive for patients to always go to get their blood work done every month. It just takes a lot of time, and sometimes people can forget. So as we can see here in this real world trend, compliance did drop off as it became more of a time burden, so to speak, for patients to get that blood work monitoring done. And so why is lab work important? So this slide here depicts a funny little cartoon I wanted to share with you all of 2 labs kind of talking about important lab work. With the first lab saying, with this formula, we will be in their line of sight when they've got any food. And the second lab says, who's a good boy? You are. So again, important lab work is not just related to cute dogs, but it's important for your health in a number of reasons. So lab work matters for insurance authorizations. Insurance authorizations are a very big part of multiple sclerosis disease modifying therapy, with nearly all, almost all of the medications requiring some type of prior authorization from your insurance to be able to access them. In addition, medication effectiveness and medication safety are also key components of why lab work monitoring is important. And it also allows us to identify trends in your health before they may manifest into an outward symptom. So going back to insurance authorizations, I'm sure you all may have heard the words or terms prior authorizations when you've gone to the pharmacy counter, had to speak with your mail order pharmacy. But I want to make sure that we're all on the same page. So I wanted to define what a prior authorization is. It's a process by which the insurance company requires the prescriber to provide the insurance company with certain documentation for review in order to determine if the insurance company will cover the cost of the medication. Now for this, there's usually a slew of questions that your prescriber has to answer and return to your insurance company for them to review and determine if they want to cover the costs of the prescription medication. Now, when it comes to lab work, and a lot of these questions that the insurance companies ask the clinics are based off of timing. So some insurance companies require blood work to be completed within a specific time frame before the coverage approval or denial can be granted. So I'm not sure, but if any of you all have had experience with a prior authorization or a denial, if you want to go ahead and put in the chat, yes, I've had a denial, or no, I've never had a denial. Sometimes I'm curious to see if anyone has had a denial because of blood work. So to kind of get a feel of some of the questions that your insurance company may be looking for with these prior authorizations, they may ask us questions about what medications a patient has tried in the past, the age, so basic demographics of the patient, sometimes the weight, depending on if it's a drug that has to be calculated based off of weight for the dose, the specific diagnoses, and then the quantity prescribed, and also the recent lab work results. So a lot of times these lab work results need to be within 6 months. Sometimes the insurance can decide within the previous 3 months of looking at the case. It just really depends on what their criteria on their formulary is decided as. So a really good example of a multiple sclerosis treatment that typically requires a lot of lab work prior to starting the agent, as well as during treatment on the agent, is Lemtrada or alemtuzumab. So this is an infusion product, and traditionally we think of infusion products as a bit more healthcare intensive because you're going in, you're being monitored in the infusion chair, it's administered by a nursing team, so it's not quite the same health labor intensity as you would imagine with taking an oral treatment at home. Now with that, most of the infusion therapies for MS do carry a bit of a heightened risk compared to the oral treatments. So for Lemtrada, it's recommended to get a lot of testing before you start the medication. So examples of the tests that are required prior to starting Lemtrada are listed here. A thyroid function test at baseline and every 3 months for 48 months after the last infusion. So picture you being on treatment and then completing your treatment, but still having to get blood work for 48 months after. A complete blood cell count with differential also is required at baseline and monthly while the patients are on treatment. Now, Lemtrada is a 2-year treatment course. So imagine having to get that monthly blood work for 2 years and then for an additional 48 months after you've completed your last infusion. Similarly, you get a serum creatinine draw, which is creatinine is a marker that we use to kind of assess how well your kidneys are functioning and clearing it out. Similarly, looking at serum transaminases. So those transaminases are those liver function enzymes I mentioned before, such as the AST and the ALT. Urinalysis is important as well. It's something that those patients are getting on a monthly basis, as well as a baseline tuberculosis testing for them as well. The reason that a lot of these tests are so important is because Lemtrada in particular can be risky to some organs, especially if left unmonitored. So for example, the reason we get a thyroid function test for these patients is because thyroid endocrine disorders can happen as a result of treatment with Lemtrada. Now, the thyroid functioning tests are extremely important because thyroid endocrine disorders can occur in about 37% of patients that are on Lemtrada. So it's important that if there are any changes going on from a thyroid standpoint that we catch these early. Some patients may progress to have autoimmune thyroid disorders such as Graves' disease, hyperthyroidism, hypothyroidism, autoimmune thyroiditis, and goiters. So it's important that we try to catch as much as we can early. These patients that are detected with having abnormal thyroid function tests while they're on treatment with Lemtrada are typically referred to an endocrinologist for further assessment, as well as recommendations for if there's any thyroid replacement or medication changes that need to occur from an endocrinology standpoint. In addition, Lemtrada can cause what's known as cytopenias, which cytopenia is basically a fancy way of saying low cell counts. So certain blood cell components is what we monitor and watch through that CBC with differential, particularly looking at platelets as well. Thrombocytopenia or low platelet count is something that can result from use of Lemtrada as well. Now, kidney issues can also pop up with this medication, which is why we see monitoring done with the serum creatinine, urinalysis, and urine proteins as well. Early signs that a patient can notice of a kidney issue or urinalysis issue may be that they have changes in their urine color, blood within their urine, decreases in their urine output, just kind of visual things that you may notice. It could be indicative that you need further treatment and further assessment just to make sure that there's no damage that's been done yet. So again, I want to emphasize that there's usually a reason that the doctors write for a blood work order for you. And this is just an example of a high-level look at what some of those Lemtrada patients go through as far as their testing. So you can kind of see each color with the pinkish, kind of purplish color representing the treatment phases. So year 1 and year 2. And then the monitoring phases represented in the green color below, with each vertical column representing a month of getting blood work for those patients. And again, we want to continue this for 4 years of monitoring after the patient has completed their Lemtrada treatment. Another reason that is important, not only from the insurance standpoint, but from a safety standpoint, is a lot of times there may be a requirement based off of the drug's approval that you have to get lab work. So it's part of something called a REMS, or REMS, which stands for Risk Evaluation and Mitigation Strategies Program. So a REMS program, many of you may have never heard of this, but is a drug safety program in which the US FDA can require for certain medications with serious safety concerns to help ensure the benefits of the medication use outweigh its risk. So when drugs are seeking FDA approval, if there are certain safety aspects that maybe get brought into question, or you determine that perhaps the medication may not be safe in a patient that has a certain level of poor kidney function, the manufacturer and the FDA can put in place these REMS requirements for having certain blood work or screenings done as for patients that are on these therapies or started on these treatments. So this would include certain pre-initiation and ongoing lab work monitoring for those medications. So the REMS program was actually finalized in 2007 and is a pretty stringent program. A lot of the requirements that are in place are really to keep patients safe. And it's important that from a prescriber standpoint, that the clinic itself, as well as the filling pharmacy, or perhaps the infusion center, do not violate or skirt these REMS requirements. It can have negative effects on the prescriber as well as the dispensing facility if they choose to skirt some of those lab monitoring requirements that are set up in a REMS program. So this statement here kind of gives you an overview of some of those civil monetary penalties that can occur for prescribers as well as institutions or infusion centers that do not adhere to those REMS requirements for patients. So what happens if we don't do our lab work? Well, it's usually not anything good. So a number of negative consequences can result for non-compliance or non-adherence with monitoring and lab work requests. So one of the things that can happen, what we want to avoid, is infections, for example. A lot of the blood work that I've mentioned previously, such as the CBC with differential, can give us a window insight into any potentially brewing infections that can occur. We also want to monitor to make sure that your immunosuppression isn't too low. So it's important that we look at those results from the blood work. Organ impairment can also result from not monitoring patients closely on high-risk medications that may be impacting the liver or kidney, for example. Drug interactions also can potentially occur. So one of the things that you may have not heard talked about a lot is drug disease interaction. So let me give you an example of what that is. A drug disease interaction is what occurs when you introduce a drug that may potentially be detrimental in a patient, for example, that has liver impairment, because this particular drug may be being processed through the liver. And because the patient may have an underlying liver impairment, when it's added on, it has an additional stress on the liver. So it's important that we monitor and screen for those lab results just to make sure there is not any potential drug disease interactions that we could mistakenly create. Another thing that we want to watch out for is the patient getting better. We may want to see certain lab parameters improve or decrease just to show signs of improved illness. So it's important that we look at those results as well. Now, from a multiple sclerosis standpoint, I guess the culprit kind of causing the issues in multiple sclerosis is the overactive immune system. So by tracking drug efficacy, we can look at whether or not, hey, is this drug helping our patient? Is it actually impacting their immune system activity, or is it not? This picture here shows you a picture of some lymphocyte cells as well as red blood cells, and how those lymphocyte cells can cause damage to the myelin sheath and through the neuron due to some of that misfiring and overactivity and targeting the central nervous system cells by those faulty lymphocytes. Given that faulty lymphocytes can be a culprit in multiple sclerosis, it would make sense to try to decrease the activity of those faulty lymphocytes, which a lot of our disease-modifying therapies do indeed do. Now, when we take our CBC with differential and we're looking at those results, we would expect to see a decrease in lymphocytes for our patients that are on those disease-modifying therapies, which for an MS patient, that's a really good thing. If we can decrease the activity of those faulty immune cells, the thought process is we can decrease some of the damage that's occurring to the central nervous system and decrease some of the symptoms that the patient may be experiencing. However, we also want to make sure that we don't decrease or suppress that immune system too much. So one of the ways that we look at that is periodic monitoring to make sure that the patients don't go too low. However, if we never take a look at those lab numbers, we will never know if the patient is indeed being too immunosuppressed until perhaps they end up in the hospital with worsened illness. So we don't want things to regress to that level. Now, this chart here depicts the lymphocyte counts for our patients that were on cladribine, which is also known as Mavenclad. So as you can see, the gray area depicts placebo. Those patients are not having any decrease in their lymphocyte counts because they're not on any active treatment. But on the cladribine, we are seeing that expected dip in those lymphocyte counts, which is helping us kind of pull together a picture of how well the drug is working for the patient. I wanted to take some time to discuss a case report of a patient that had progressive multifocal leukoencephalopathy, which is a mouthful to say, and most of the time you probably heard of it as PML. And most of the time when you hear about PML, it sounds very, very scary. It is an extremely rare illness that occurs, but the main culprit or the cause of it is really the JC virus, and I'll talk a little bit about that in a second. But in this particular case report, there was a 40-year-old male who was on Tysabri. He had been on Tysabri for quite a long time for his relapsing remitting MS. He presented to the clinicians with a 7-day history of visual disturbance, leg weakness, pain, and unsteadiness. Now, that kind of sounds very similar to some of the symptoms that our MS patients do complain that they have experienced. So the patient was initially diagnosed as such, having an MS relapse, and was treated with IV steroids, and an MRI was ordered. Now, on this patient's MRI, it was determined that there were lesions in an unusual space and lesions that were very active at the time. Upon further workup and investigation into the patient's case, it was determined that he did have a history of a positive JC virus. So JC virus stands for John Cunningham virus. It is traditionally a very benign virus. Most people get exposed to it in childhood, and normally our immune system is pretty on top of it and is able to suppress it from causing any type of damage. So most of the time it's pretty non-bothersome to folks. However, in the perfect setting type of storm, such as in a patient who's got a increased level of immunosuppression, JC virus can become very active and seep into spaces that it's not supposed to be in, such as the brain and the central nervous system. So that's what happened to this patient. The JC virus had become very active as a result of his long-term immunosuppression with Tysabri, and it had infiltrated his brain and was causing those symptoms. They did additional testing on the patient, and investigating his case had determined that he had previously been positive for the JC virus and had a higher level of JC virus activity. So the higher the activity of the virus, of course, the more chances it can cause some bad outcomes for folks. And the reason we care so much about PML is because it can potentially be fatal if untreated. Now, again, it is extremely rare that it happens, with most of the time it being associated with a long history of Tysabri use, as well as severe immunosuppression. So one of the things we look at is the JC virus testing for those patients. And we also want to take some time to look at the absolute lymphocyte counts. For those absolute lymphocyte counts being less than 500 is a huge indicator that, hey, this person may potentially be overly immunosuppressed, and we want to watch and make sure it's not opening the door for any significant dangerous viruses for the patient. So this slide kind of goes over the course of the patient's case, with him having kind of the visual disturbances, leg pain and unsteadiness kind of at the initial onset. And then over time, you see his symptoms progress to symptoms that definitely sound more severe than an MS relapse. So patient having a worsened swallow reflex, a weak cough reflex, difficulty clearing secretions. Patient also progressed to having seizures as time went on, and eye flickering and unresponsiveness. So it is important to try at all costs to make sure you are indeed compliant with some of this testing, because you may or may not know what potentially dangerous side effect or risk that the prescribing team is trying to look out for early. Another important reason for making sure you're compliant with your blood work is being able to track and trend. I can't tell you how many times that while staffing inpatient, that there have been a patient who maybe didn't see the doctor for years and comes in, and we get blood work and we're like, we have nothing to compare it to see if they're improving, worsening, or what rate they're getting worse or better. So it's important to establish those periodic monitoring points where you'll have something to reference back to and compare it to if your health deteriorates or declines over time. Or even if it improves, you'll be able to look back and say, hey, I can see those changes that I'm making are indeed improving my numbers. So from a patient standpoint, that was a lot kind of thrown at you guys from the different types of lab tests. So what should you really be checking, or what should you focus on from this presentation? So The next time you are at your doctor's office, I want to make sure that you ask these key questions. So when was my last, whether it be a CBC, MRI, CMP, JC virus testing, ask when was your last one. It's important to also be able to eyeball it so you can see yourself and say, okay, these were my numbers. Make sure you understand what is normal or the expected range and where your results fall on that range. And see if anything looks off. If there's something, for instance, highlighted in red on your results in your labs, ask questions about it. What influences that number? What can make that number better? What can make that number worse? And then also be able to make sure you're asking, when is my next lab? So checking to know your anticipated CBC or CMP. Depending on what treatment you're on, it may be next month, it may be 6 months. Every case is a little bit different. So, but make sure you're knowing, you're thinking in your mind, when is the next time I need to go get my blood work? And then also keep in mind, you should be able to access your results on demand, whether that be through an app like MyChart that your hospital system or your health clinic has set up, or whether it be through the Labcorp or Quest or some type of freestanding lab that also has an electronic results retrieval system. Make sure you have access and can log in. If you're not computer savvy, get somebody that you trust or your caregiver to help you log into that and be able to reference it, because it's extremely helpful for you to be able to pull those results if you're seeing a new practitioner, or if you're seeing an outside clinic that you're not normally used to, or if you're getting a second opinion from a new doctor. And there's different ways that you can kind of help keep yourself on track as well. The easiest way is to get the labs done at the clinic visit. If your insurance allows it, and as well as your clinic staff has the means to getting that blood work done while you're in the office, please get it done while you're in the office. That saves in the delays in getting the results, as well as making sure your doctor's office doesn't have to track down or call people or request faxes to get those results done. If you get it done in their office or clinic, they get those results back. Arranging lab appointments before you leave the office. So if your provider has placed in electronic lab orders, let's say to go to a Quest or a Labcorp, make sure you either log in on your phone and try to set up that appointment before you leave the office. That will also increase the communication between you and your provider so that they can say, oh, she has an appointment that she's scheduled for 2 weeks on Saturday to make sure she gets her lab done. Your provider will keep in the back of their mind, or sometimes make a note to themselves to check online for those results or in the system to see if they've been resulted after your scheduled appointment. Another thing you can do is also set an electronic reminder. So our smartphones are super smart nowadays. You can use a Google Calendar. There's reminder apps. There's also all kinds of clocks and alarms you can set to remind you to get your labs done. So the more proactive you can be to rely on those external brain sources, so to speak, it will help you stay on track and compliant with getting those labs work done. Those are some references to what I presented on. And if you guys have any questions, I would be happy to answer them. But that concludes my presentation for now.
Wonderful presentation. Thank you so much. That was so informative. As Dr. DeBerry was saying, we're ready to ask questions. If you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on your phone. I will call on you and then you'll be able to unmute to ask your question. So we will open the floor up if anybody has any questions at this time for Dr. DeBerry. So far, we do not, because that was just an incredible presentation, and I think you covered so much information.
I see a couple of comments in the chat about people who had experienced some denials and prior authorizations. And I see
Yeah.
Bonita commented her neurologist draws them while she's getting infused. So that is pretty awesome.
Absolutely. We'll leave it open for another minute or so. Okay, we do have a question. This is from someone who's asking, what tested is needed for Mayzent?
Quite a bit, actually. Quite a bit for Mayzent. Mayzent actually has some additional genetic testing that needs to be done aside from your traditional, like a CBC with differential, a CMP to check on your liver function. So there's a slew of tests that need to be done for that. The nice part of Mayzent, though, they do have what's called a specialty hub set up for commercial patients. So if a commercial patient, meaning a commercially insured patient, so not Medicare or Medicaid, those patients are able to get coverage for those labs for the pre-testing done, covered by the drug manufacturer for commercial insured patients. So if you are in that situation, I would highly recommend taking advantage of that pre-testing that would be covered by for commercial patients by the Mayzent team.
Okay, fantastic. We have another question. This is from Shailene. Shailene asks, low dose naltrexone, thoughts while in Texas for Ocrevus?
So for Ocrevus and low dose naltrexone, I'm not quite sure exactly where you're going with that question. Is it more for just using it and if it was contraindicated or not? So we have to give a little bit of elaboration on that one.
Maybe. Shailene, please, if you want, you can add a little bit more context in the Q&A. But yeah, I think you're just trying to figure out your thoughts on specifically what the dose was, maybe. But we will get back to Shailene. We do have another question. This is from Becky, who asks, any specific labs needed before Ocrevus infusion?
Yes, so Ocrevus is definitely going to be one of those medications that you do have that pre-testing. So making sure you're getting your CBDC, CMP, and then also testing for those patients to get a tuberculosis testing to make sure that there's no underlying potential active tuberculosis for that medication as well, because that can actually flip an active TB patient over. I do see some more questions. Kathleen said, I just started Aubagio today. I need to go for lab work for 7 months. Anything after? And if so, how often? So yes, so for the Aubagio, you would want to be testing monthly for 6 months when you're first starting the treatment. And then once you get to that, that 6 month mark, then it switches over to every 6 months. It may be asked for you to get more frequent testing than the 6 months once you get over that threshold, but it really just depends on what your numbers look like and what your clinician, you know, kind of comes into agreement with you for based off of your risk level.
Okay, thank you. And Shailene actually has responded and she says, yes, an exclamation point. Is low dose naltrexone safe while in treatment for Ocrevus?
So there are no like specific drug contraindications for the low dose naltrexone while you're on the Ocrevus, but sometimes there are patient issues. So it's always best to check with your doctor to see if that would be a good option for you. But just based off of like drug labeling, there's nothing drug labeling wise that would prevent those two combinations.
Okay. And Leslie asks, and forgive me, I'm learning some of these words as we're going. So when taking Rituan, I'm going to spell this out, Rituan, should WBC be higher? And how often is JBC test be done?
So it looks like two questions there. So
yes,
I
looks
believe
like
it might be a typo there about Rituxan. Should the white blood cell count be higher with the patients that are on Rituxan? Is the first question, and the second one was how often is JCV testing to be done? So excuse me. So for the white blood cell count, you're not necessarily looking just at that for it, but if it is a bit elevated, then you'd want to investigate that a little bit further and just make sure that there's no additional infections or anything going on with that. Now for the second part, the JC virus testing, so it kind of depends, honestly. And it depends mainly on what drug you're on as well. So for patients that are on Tysabri, it is recommended to have that JC virus testing done at least annually. And depending on how that person's tracking and trending on those results, sometimes clinicians may increase it or decrease it just based off of those results. But at least for that. And then sometimes what can happen is just because you're negative, let's say 1 year when you're taking that JC virus, it doesn't mean that you will stay negative. You can have what's called seroconversion, and a patient can flip to a positive on JC virus, even though they previously tested negative. So it's important to periodically get that test. Sometimes the frequency can be adjusted depending on, the drug that the patient is on. But particularly for Tysabri, it's one of those things that if you're treating that patient, you want to check it and look at it periodically just to make sure it's not going wacky.
Mm-hmm. Okay, fantastic. So you might have already kind of covered this in a previous question, but Anonymous wants to know, is there any recommended test for patients on Ocrevus?
So yeah, so prior to starting Ocrevus, you are recommended to get like a CBC test, a CMP test, making sure that the patient doesn't have tuberculosis, different things like that. So pretty much all of the MS treatments, I would say, except Copaxone is usually the easiest, but I would say, yeah, just about except Copaxone. You may still want to get liver testing just to test it and check, but every one of them will require a pre-testing or an ongoing testing of some sort.
Okay, thank you. Another individual would like to know, what would be the ongoing testing for Mayzent? I've been on it for 1.5 years.
So for Mayzent, you still want to make sure you're checking those general things, the CBC, CMP, liver function tests for those patients that are on Mayzent. Now, you may sometimes, depending on the patient's risk level, have to have additional screenings for like an EKG or something, but it really depends on the risk level. But those are kind of the main things that you're looking for in Mayzent that applies to just about everybody.
Okay. Now, I'd just like to leave the questions open for another minute. And Dr. DeBerry, thank you so much. This has been so incredibly informative. I can speak for everyone, as well as Nohora, who says awesome presentation. So we truly appreciate it. Was there any more questions from the audience at this time? Okay. Well, that brings us to the end of our time. If you missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings, or sign up for our newsletter to learn about upcoming events. Our next teleconference will be Town Hall. Bring your questions with Dr. Aaron Foster on Thursday, July 7th at 6:30 p.m. And as you leave the conference today, a survey will appear on your screen. We ask you to please take a moment to give us your feedback on this program and your suggestions for future topics, so we can be sure to provide you the best programs possible. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Adrienne DeBerry. Thank you so much for your time you spent to prepare and share the information with us. Have a wonderful day, everyone. Thank you so much.